Hi, welcome everybody to webinar number 5, season number 6, the eye in cystinosis. We have an amazing panel. My co-moderator, Dominique, bonjour, ça va?
Hello, everybody from Paris, France. Yes, of course, everything's good.
Okay, so let's get cracking. We got a lot to cover. We have an amazing panel today, really. We have real experts who have written about the eye and cystinosis, and more importantly, we have a phenomenal nephrologist, professor of pediatric nephrology at Alberta Children's Hospital. Julian Midgley is one of these rare breeds who did his preclinical medicine at Oxford, and then did his clinical medicine in Cambridge. So I'd love to know, Julian, who you support when the boat race is on. Do you have any allegiances?
My younger brother lives in Cambridge, so I've got to go for Cambridge.
Fair enough. This is a picture of Professor Midgley with a patient with cystinosis, and he's incredibly dedicated, really well recognized. You can see him getting an award here, and he's also done a 100-kilometer walk to raise money for his nephrology group. And we're very, very lucky to have you today. Thank you very much for joining us, Julian. I want to introduce Sasmita Biswas, consultant ophthalmic surgeon and pediatric ophthalmologist at Manchester Royal Eye Hospital. That's the hospital there. He's the clinical chair in the Faculty of Biology, Medicine and Health at the University of Manchester, and as I said, Manchester Royal Eye Hospital. It was a great privilege for me to have Sas as a colleague when he did his fellowship with me in Great Ormond Street. Oh gosh, more years than I'd like to count. And clearly he still has a great deal of affection for me, because when I looked on the Manchester Royal Eye Hospital website, that's me up there, Sas, just to let you know. That's my watch, and that's my hairy arm. But thank you so much. This is Sas as well, with a number of our ex-fellows all together at the World Congress. So Sas, really looking forward to your talk. You've published extensively in this area, and I look forward to hearing from what you have to say. Well, what can I say about Patrick Hamel? One of life's gentlemen. He is the division chief at the for pediatric ophthalmology at Saint-Justine Hospital in Montreal. I am so grateful to know him. We were fellows together 27 years ago. And some of you may recommend Boon Long Kwa and Stephanie Goey. And we've had a great friendship ever since. He's an amazing pediatric ophthalmologist. This is Saint-Justine Hospital. I've had the privilege to talk there. And this is his lovely daughter. Patrick, thank you very much for joining us. Last but not least is Stephanie Dotchin. She's section chief of ophthalmology at the Department of Surgery and clinical associate professor at the University of Calgary. These are her 3 lovely daughters. Apparently, Stephanie, you're a Swiftie, and you went from Canada to the USA to do a concert and then flew back the same day. That's impressive. Amazing. Thank you for being on board. And this is a lovely picture of her family, her partner and her 3 kids. And I think this sums Stephanie up. This is some stills taken from a talk she was giving on YouTube, and you can see how passionate she is, and that's what we love. And she works at Alberta Children's Hospital. What can I say about Dominique Bremont-Gignac? Dominique is more than qualified to moderate this session. She's been involved in the clinical trials for cystinosis eye drops. She runs the Ophthalmology Rare Eye Diseases Center and sees so many children with cystinosis in Paris, where she's the head of the department. Over to you, Dominique.
Okay, that's great. Thank you very much for my co-moderator. So he's so well known, so I have nothing to say. But of course, Professor Ken Michaud is Division Chief of Pediatric Ophthalmology and Strabismus and Adult Motility, Medical Director, Digital Health, UPMC of Pittsburgh, of course, Children's Hospital, Executive Vice Chair of UPMC in Ophthalmology. Probably I forget a lot of things. And he has published in UBM in cystinosis a long time ago and drug development for cystinosis crystal. So great thanks, Ken, for all this job. So that's very good because you will have the opportunity to get audience questions. And so type your question on the YouTube comment section, please. It will be a pleasure to answer with such a great panel. And so let's go for that. And second point, if you need attendance participation certificates, please send an email to admin@wspos.org. So great to have you on board with us. And so now it's my great pleasure to invite Professor Julian Midgley from Canada, a pediatric nephrologist, to talk about vision and vital organs, a cross-specialty approach to cystinosis. Julian, it's a pleasure. It's up to you.
Thank you very much indeed. So we've got an interesting clinic at the Children's Hospital in Alberta because we see adult patients as well as children. We've already seen a picture of this hospital from the introductions. And our children go from, well, birth essentially up to a couple of adults in their 50s who had juvenile cystinosis. Now, this hospital looks great in this particular picture, but a couple of weeks ago we were battling with a bit of snow, but fortunately that's gone again, and who knows if we're going to have any more snow before then, before the summer. So I'm going to talk a little bit about cystinosis, sort of set the scene, and talk a little bit about the fact that cystinosis affects many organs, including the eye, just to give you a bit of background to this very difficult condition. Most people with cystinosis present in infancy. They have poor growth, polyuria, constipation, and it's sometimes a very difficult diagnosis to make. You can see that from these pictures here, we have crystals in the various organs that have been sampled in this individual who unfortunately died at about 8 years of age. This is a publication as on the bottom of the slide. But early diagnosis really does improve long-term renal outcomes and probably other outcomes as well, because the crystals have an insidious and progressive effect on organ function. Now, before cysteamine was available, untreated people had kidney failure by about 10 years of age, probably hypothyroidism by then, bone deformities, extremely short, very unwell, and probably died in their teens from a form of dementia. Even if they had a kidney transplant, it was not a particularly good prognosis at all, and of course that's changed. It's also recessive, incidence of about 1 in 100,000, and the whole issue with this condition is an impaired transport of cysteine out of cellular lysosomes, and I'll show you a bit more about that. But just to emphasize the fact that it's a multi-system disease, the brain, I've already talked about, there's some no cognitive issues in particular, but some processing issues for math and spatial orientation. Swallowing is particularly difficult for adults if they have a significant myopathy, and they have a rather sort of dysphonic voice if they have laryngeal involvement. Skin, the people tend to be blonde. Kidneys, we can talk a little bit more about that in a minute, but other organs, pancreas, diabetes becomes an issue. Hypothyroidism, even with treatment, may become an issue in the 4th decade or so of life. Lungs, males are infertile, possibly a few sperm in their early teens, but after that there's an obstructive azoospermia. And bones and muscles, in particular skeletal muscles, very severe myopathy in some individuals, depending on the amount of adherence to cysteamine. The gastrointestinal issues are partly due to the disease, but also partly because of the cysteamine treatment, which produces significant adverse effects as well. And of course, the eyes, which you're going to hear a lot about today, particularly photophobia. Blindness is not so much of an issue now because of the treatment. So what's going on in this disease? Well, this is a lysosome. You can see the cross here of the cystinosis transporter being absent. It's a recycling bin, so when proteins are broken down, they are broken into their constituent amino acids. And cysteine dimerizes to cysteine, and cysteine can't get out of the lysosomes. It builds up, crystallizes, and disrupts cellular function. It affects the kidneys first. It's very metabolically active, proximal tubule, causing the Fanconi syndrome. And so the treatment is with cysteamine, which enters the lysosome, binds with cysteine, disrupts the cysteine dimer, forms cysteine, which goes out of the lysosome through an alternative transporter. The cysteine transporter is not particularly active because the cysteine is dimerized into cysteine. So this is an amazing treatment because it decreases the effect of cystinosis on the various organs in the body. But it's not a very nice medication to take. It's really difficult. It causes the GI effects, adverse effects, and also halitosis and such like and so forth. The treatment with cysteamine is difficult because it's now taken every 2 hours. The blue pills here are the delayed release cysteamine, which some patients will be taking 3 times a day to try and decrease the GI adverse effects from a fairly large dose of medications. Halitosis is an issue. Monitoring of various organs really begins with the kidney in the first few years of life with a large amount of electrolyte replacements. It's rather like filling a bucket because there's uncontrolled losses out of the kidney and you have to put more electrolytes into the patient to try and keep those levels normal. But this kidney issue, instead of having kidney failure at about 10 years of age, you can extend it into the 3rd decade of life. And a couple of patients that we see in Calgary still have their native kidney function after diagnosis in infancy into their 30s. Transplantation used to be in the early teens, but has been extended up until the late teens or even into the 20s. And you can see that there's a line here of the 2000 and 2010 showing that the prognosis is even better nowadays. Very exciting, we've got patients being diagnosed because they're SIBs and they have cysteamine from very early on and they may well be doing very much better. And I've got a patient who's had a couple of pregnancies with their native kidney function, which is very exciting. And now there's some trials going on with stem cell treatment, which is amazing. The first patient who received that was from Calgary and is off cysteamine and doing very nicely. But that may not be available to everybody for quite a while yet. Of course, we have to monitor lots of other things, the thyroids, the gonadotropins, muscle strength, bone mineral density, glucose, hemoglobin A1C, and of course the eyes. Eye health is very important to children and their parents. They really want to know about the crystal burden. They want to know, is it better or worse than the last visit? They want to know about their cornea because they know about the effects of cystinosis on their eyes because of the possible keratopathy, which they really fear. And they also want to know about their retinal health, hoping that they won't have any issues. And of course, all the other eye things, which I'm sure you're going to hear a lot about from Dr. Dochin, who's my colleague, and the others that you've been introduced to. And I think that one of the things that I'd like to emphasize is that The eyes is just one facet of cystinosis, and it's a very difficult disease to treat, and it's a relentless condition. We've got many things going on in these patients' and families' lives. So understanding more about what's going on with cystinosis in the rest of the body can temper the idea about how we should approach the eye health. And just my last slide of me and my granddaughter in my MGB with my MGA just to the side there. I'm not sure, she's quite old enough to drive yet, but hopefully she'll be a good driver in the future. So there's a little bit about cystinosis for you to start off with in this webinar.
Thank you very much indeed. Thank you. Before Dominique introduces our next speaker, I just want to let people know we have, so what happens on YouTube, people like to tell us where they are from, and also I get messages. So at the moment, we have listeners from India, USA, Canada, Italy, France, Hungary, Chile, Sweden, Argentina, Brazil, the UK, and Syria. So it is genuinely a global webinar. All yours, Dominique.
All right. Okay. Just to ask for Professor Stephanie Dochin from Canada, from Calgary, and she will speak about the everyday challenges of cystinosis. Great, Stephanie. Thank you very much for presenting that.
Thank you, Dominique. Good morning, good afternoon, and good evening to everybody out there. As Dr. Midgley said, I have the privilege of working with Dr. Midgley, and we at the Alberta Children's Hospital. I will underscore, and I think we'll all agree that team approach to these challenging patients is very important. I have no financial conflicts or affiliations to declare. So when I'm looking at a patient with cystinosis, I look at it in two basic parts. I look at the retinopathy and think of the retinopathy as being a systemic reflection of the systemic disease and systemic cystinosis. As retinopathy can actually be prevented by oral cysteamine, which Julian discussed about for the treatment. And then I think of the corneal changes as independent, as the systemic treatment does not have adequate concentration, does not reach adequate concentration in the cornea. And this is thought to be because the cornea is avascular in nature. And so the treatment for the cornea and corneal crystals is independent from the systemic treatment. From a retinopathy standpoint, pigmentary retinopathy is the earliest ocular involvement that you can see with cystinosis. It's been documented to have changes occur as early as 5 months of age in our cystinosis patients. The most frequent presentation is bilaterally with with peripheral hypopigmentation and modeling of the retinal pigment epithelium. The cystine crystals can also accumulate in the retina, as is traditionally thought, and you can see a crystal retinopathy. But this paper came out in 2021, looks at the use of spectral domain OCT for cystinosis, and it actually found that they hypothesized that the corneal crystals seen in all eyes, that retinal crystals are seen in all eyes, including asymptomatic pediatric patients, whereas previously it was thought that crystallized retinopathy did not occur in every patient. They go on to suggest that retinal crystal accumulation is actually what is associated with reduced visual function. And it's already known that corneal crystal accumulation is poorly associated with visual function. They also, during this paper, completed a scoring system, which they call the retinal crystal accumulation crystal score, by counting crystals, and found that the more crystals that you found in the retina was associated with a higher cysteamine C concentration. And they put forward the suggestion that this is a possible way of monitoring overall systemic cystinosis levels and how they're actually doing. To me, this did underscore the importance of the patients taking their oral cysteamine medications for the prevention of end organ damage, including including the retina. And just to remind ourselves as ophthalmologists that we should be asking how the patients are not only doing with their cysteamine eye drops from the corneal crystals, but also how are they doing taking their oral medications. This is a picture of one of our patients with the retinal choroidal crystals that you can see. What you see are these hyper-reflective dots on the spectral domain OCT. They can all be found in all layers of the retina and the choroid. And based on the study that I previously mentioned, the most common location is the choriocapillaris, followed by the internuclear layer and the ganglion cell layer, with the internuclear layers occurring at the junction of the OPL or the IPL, which you can kind of see right here in this picture there. If we move on to the corneal aspect of things, compliance with treatment for keratopathy, I find, is very different than systemic compliance. Corneal crystals are different, and they tend to appear later, starting at around 16 months of age. Within the corneal, patients develop these needle-like deposits that you can see, and they accumulate over time. They can also be found in the conjunctiva and other areas, which you'll hear my colleagues also discuss. These lead to the symptoms of the photophobia, blepharospasm. They can have foreign body sensation and pain. Patients can then have filamentary keratopathy and peripheral corneal neovascularization. And if you look at the image here, the one on the right, I don't know if everybody can see that. If we look here, you can see a mild form, and then this is one of our patients in their 20s with significant amount of crystals. And here you see that peripheral neovascularization, and this patient is in their 40s. Oh, hold on a second. There we go. For all my patients, I also do an anterior segment OCT, and this can determine the depth that you see of how far the crystals go within the cornea. And here you can see in this patient that they have crystals throughout their cornea. And so I actually find the anterior segment OCT very easy to do and very helpful. I find that the patients actually tolerate the OCT well, even if they have photophobia. But I will say that sometimes it does take some patience and just allowing the patient time to adjust to the testing, and they will be there for many hours, and we do try and coordinate our visits where the patients can see myself and the nephrologist in one day, as they do come very often. Looking at treatment for the eyes, there are two options for corneal cystinosis. One is a drop formulation, which is the one on the left, and one is a gel formulation. Prior to the gel formulation at our center, we did the drop formulation, and our pharmacy actually compounded it. The challenge with the drop formulation is that it needed to be placed in the eyes hourly, and because of the instability of the medication, required cool storage. And I will say that given the complexity of the disease and the disease burden, as Julian mentioned, with all the other medications, I would say the drop formulation for our patients, the compliance was very poor, almost impossible, especially to get in hourly while they were awake. The gel formulation is used 4 times a day. And what the gel formulation contains is carboxymethylcellulose sodium, which makes it more viscous, which prolongs the contact of the active ingredient with the eye, and it allows the reduction in the dosing frequency. To date, in our patients, I would say the compliance has been very good in that the patients are getting some drops, but none of our patients have been at the dosing frequency suggested of 4 times a day. We've gotten to 3 times a day with our patients, but never 4 times a day completely. Complaints that the patients have include burning and stinging. Also, because of the viscous-like nature, and our patients describe it typically as honey-like consistency, they do find that it is challenging to get into the eye. And so it does take time. Some of our teen patients in young 20s, the patients will oftentimes I've had patients say that they don't want to put it in because it does affect their makeup. And so they'll put it in the morning and the evening, but not want to do it during the day. But I do think that the gel formulation has really improved our compliance and helped our patients. The symptom that most patients describe a reduction in is photophobia. So with that, I will allow some of the other colleagues to talk about the other findings. So thank you. And this is a picture of my 3 girls and with the array of emotions, which I think our cystinosis patients probably feel sometimes on a day-to-day basis dealing with their condition.
So thank you. This is great, Stephanie. And the last photo is absolutely wonderful. So thank you very much for this talk. And so I think this is the time to ask some questions. Would you like Ken to begin, or
sure.
Okay, very good. So because I have some too.
I wanted to ask Julian some questions. Julian, I worked with William Van Toff at Great Ormond Street when I first was a consultant there, and I remember William talking to me about that the adherence to treatment was one of the big obstacles. And are you familiar with the Christobs study where they looked at delayed release cysteamine and compared the adherence of delayed release as opposed to the other regular cysteamine systemically? And I believe that they showed that the adherence was better. Got any comments on that?
Yeah, I was actually a senior house officer with William back in the time when I was doing some training in guys, so I know him very well. And he was very keen on cystinosis. I remember he was looking at rectal cysteamine, which fortunately never took off. But yeah, no, the twice a day delayed release cysteamine clearly is a great advantage. And the biggest advantage is that you don't, the parents and people don't have to get up at night and wake up at night to take the medication, because it was not 4 times a day; it was every 6 hours, which is kind of ludicrous in some ways. The twice a day medication clearly has better adherence. The only problem is if you miss 1 dose, you kind of missed the equivalent of 2 doses of the every 6-hour medication. But it's quite clear that parents were really keen on this medication coming into play. Just about everybody is now using some delayed release cysteamine in our clinic. There's a few that still wanted to do the immediate release during the day and the delayed at night, which is the way we usually transition to delayed release. But just about everybody now has transitioned. Adherence is undoubtedly better.
So can I ask you something? What I've noticed is that they 20 years ago, even maybe up to 5 or 6 years ago, these lovely families would come in, and the kids, when they would, because as an ophthalmologist, you're very close to them, on the slit lamp, and they would have this sort of kind of like a little odor coming from their breath. And I've noticed that seems to have disappeared. And when I was speaking to one of the parents, they said that there was this new, I don't know if it's the delayed release, but this new formulation where you don't get the breakdown and you don't get that kind of sulfide odor or something. I don't know what it's from, but is that, does everybody have access to that now?
Yes, well, not every country, but quite a few countries now have the delayed release. So the cysteamine is in granule form and it's coated with an enteric protector, and therefore can pass through the stomach. So you don't get the immediate release of the smell. People still do get smell. It tends to be a little later rather than earlier after taking the medication. Initial studies kind of suggested that it might be a little bit less, but it varies a lot from patient to patient. But people still do get some smell but a little later in the day rather than earlier.
Sas, I remember when we talked about this once, maybe a year and a half ago, you said that the delayed release was not available in the United Kingdom. Is it now?
No, it's still not available. So we still have the all our
older
patients on it. Yeah, on the Cystogon. I don't know whether because I remember reading somewhere about riboflavin being used to try and limit the halitosis that can be associated with the use of the immediate release cysteamine. I don't know if Dr. Midgley, you've got any sort of comments or experience of that?
Yeah, the two main additional medications that people use is riboflavin, and some people swear by it, and the other one is chlorophyll. Some people take one or the other, and they think that it helps. Some families have said that they think chocolate milk makes a difference. But I think that's probably just the children liking chocolate milk. But yes, riboflavin, chlorophyll, possibly chocolate milk.
Dominique, go ahead.
Yes, just to remember also by the eye drops, because when I just began to see cystinosis in children, it was in the years 90, we had a formulation from the pharmacy of the hospital. And at the time, it was supposed to be 6 times a day. And clearly, there was a compliance problem for half of the children, but the other, they were instilling 6 times, but they were instilling 6 times a day. So I think that 4 times a day is not unsustainable. It's we can do it. And probably even if there is a gel which gives a better coverage of the cornea longer, I think it should be important to explain to the parents to go this way. What do you think, Stephanie?
I agree with you, Dominique. I think it's easier for the younger ages. Where I see the biggest challenge is as our children enter teen and early 20s, and I see compliance drop off. And they'll say, oh yes, I'm getting it in 4 times a day. And then you start to really kind of pry and, oh, maybe it's once, maybe it's twice. And they're, and that's where, you'll hear it messes with my makeup, my mascara runs, it stings, it hurts. And so I think I always stress the importance of 4 times a day. If my patients aren't getting it in, if they're only getting it in one time a day, I do shorten my visits, like the frequency that I'll see them will increase to try and help them, to coach them through it, to increase their frequency. And then just always kind of going through the importance of the drops and why it's so important in the long term. As they get older, like our patients in their 30s and their 40s and their 50s, like you saw that gentleman with that neovascularization and keratopathy, it's much easier to convince them.
No, I understand. And do you have, by this way, for neovascularization, do you have any idea of the mechanism of only, do you think it's limbal insufficiency?
Yeah, I do think it's most likely limbal insufficiency, to be totally honest. Yeah, that's what I think it is.
Okay, all right, thank you.
So
yes,
I was going to bring Patrick and Sas into the conversation. What is your experience with the different drops? And I just wanted to make clear to the audience, about a year and a half ago, I did speak for Recordati Rare Diseases on a webinar, but I have no other conflicts that are current. And as you know, Recordati Rare Diseases has given us an independent medical education grant to be able to do this webinar and a following webinar that I'll be talking about. So that aside, Sas, Patrick, what is your experience?
Patrick, do you want to go first? And
Oh, okay, that's sorry. So yeah, I would say we have available either the cysto drops or the compound 0.55 system in where I am, and I have to say it depends. It really depends. I only first of all I only see children, so I don't see adults, and basically. We let them choose now. So some are very happy using cysto drops, and they're going to be using it like from twice to 4 times a day, as Stephanie said. And some are happier to use the compound drop, and some will do like 6 times a day. I'm amazed they will do it. So that's my experience at the moment. We kind of get the same results using one or the other, but it's really up to the children and the families.
I think in my experience, so our first line treatment is now cysto drops in the UK. We still have the aqueous compounded 0.55% eye drop available. The experience is mixed. We certainly have patients who actually feel much better using the cysto drops, and parents, when they've had some difficulties with the cysto drops, they're offered the aqueous compounds, but actually they prefer to use the cysto drops because it's 4 times a day, whereas the other drop is more frequent. And actually, in terms of their lifestyle, it's much easier to stick to the cysto drops. So they do, when they're given the choice, they do tend to go for the cysto drops as well. But we have had some patients who really not tolerated it, the viscous preparation, and have reverted to the back to the aqueous suspension, aqueous mix.
So
Thank you, Cystinosis.
go ahead.
Yeah.
Sorry.
Okay, I have the same experience in France, and we have only cysto drops doing because we have no more compound in the pharmacy, and so I think they feel better, and it's easier to have 4 times a day. And I insist for the 4 times a day, but even if I cannot check every child, of course, they'll have the same experience. Thank you for speaking, and you can.
Julian, I wanted to ask you something. As ophthalmologists, we are, of course, focused on the eye, and we can go a bit crazy about, telling parents, you've got to put the drops in, you've got to do this, you've got to do that from an eye point of view. But from your perspective, when can you sort of give us a gestalt? If you have, the first 5 years, the second 10 years, and then into the late teens and early 20s, what effect does our language as ophthalmologists have on the well-being of the parents and the patients? Have you seen that you've sort of wondered sometimes and thought, God, I wish the ophthalmologist hadn't said that. I wish they would just lay off a little bit because this kid's got more than enough problems. This is your opportunity to tell us what terrible doctors we are and how we don't need to speak, how we don't know how to speak to people properly. And be frank. I mean, I think this is important.
Yeah, well, I mean, obviously, we're very grateful for the ophthalmologist because we can't do what you do. I mean, I can, kind of use an ophthalmoscope sort of thing. I'm not quite sure if it's for the ear or the eye, but so I think there are various aspects. A couple of points. So when this diagnosis is made, the parents, probably around about a year of age, or a little bit less, hopefully, perhaps a little bit more. The parents are relieved, but also devastated because they're relieved that someone's actually made a diagnosis of what's going wrong with their child, and often they haven't been able to find out what's going on. But they're devastated because they learn about its multi-system effects and such like and so forth. And then they have to have this myriad of medications, which are very difficult. And so I think that the first issue is when to start the eye drops, because the crystal burden may not be particularly great at the beginning. There may not be very much in the way of symptoms. The downside of not starting drops may be a little bit less. On the other hand, some parents say, gosh, perhaps we should have started the drops earlier because they're so used to taking all the oral medications. Perhaps they would have got used to taking the eye drops if we'd started it earlier. It had just been part of life. So that's the second thing. To address your point about whether or not people want to know more or less, in general, families, individuals with cystinosis are really well educated about cystinosis. They have great support, peer support through social media. They go to family conferences. They really do know an awful lot about cystinosis and effects on eyes. So they want to know, the bottom line. How are their eyes? How is the retina? What are the issues? So I don't think you should hold back. You should tell them what's what and encourage them to use their drops. We do. I never start off by assuming that anybody's taking cyst drops 4 times a day. I usually start off, are you taking any? The last thing to say is that cyst drops have had feedback for the dropper because it's actually quite difficult to actually use. So there's a new so-called Cystitouch TM Comfort dropper, which is going to be available at least in the US. We found out at the Cystinosis Research Foundation Day of Hope last weekend that this is going to be available in Canada for a while. But apparently it's going to make it easier to use. So we'll see if that improves adherence, because, some people think it's a glacial sort of drop into the eye, which just adds to the pain, not the pain, but the pain of having it. The last thing I'd like to ask the ophthalmologist here is, what about the preservative? Because I think that was one of the good things about the compounded drops. If you could get it made without preservative, perhaps it didn't hurt so much, and there was less adverse effect on the eye because of preservatives.
That's a great point. I think we discussed this briefly in our practice session yesterday. Sus, was it you or Stephanie or Patrick who raised this?
Yeah, I mean, I think that the preservative is potentially an issue if you use it more than 4 times a day. Some people are obviously reactive preservatives anyway. So that's why it is helpful for us to have still the aqueous the preservative-free eye drop available to us in the UK. So we've pushed quite hard actually to maintain that availability, because we knew that some people will react to preservatives. So yeah, it is an issue, and it will limit it to at least 4 times a day. At the most, 4 times.
Before we go on, we have a question from, I'm going to name, I don't normally name the question, but this is Warren Hindle, who is, a bedrock of pediatric ophthalmology in Canada. And Warren asks, have spray forms been attempted for these children? So before anybody else answers, can I just tell you that from the year 2000 until 2024, I have worked with 2 basic scientists, one at the School of Pharmacy in London, Catherine Tulu, to try and create a long-acting histamine eye drop. And it's very, very difficult because of the molecule itself. It's not easy to do that. And then I worked with Morgan Fedchak here at the University of Pittsburgh, where she's developed some nano wafers. I think the problem with the spray is that you would not be able to uniformly get that molecule onto the eye. That's my experience. It's not an easy molecule to work with. I just wondered if anybody else had any thoughts or had any experience.
Yeah, I think we have to know that lubricants have been developed by spray. Yeah, you probably remember that. And we've seen that it doesn't work very well. And it's probably difficult because we have, much more for children because they have the reflex of blinking. So to spray with the blink, so you do not give such a good quantity of such drops of histamine drops. So that's why it's probably too difficult also. That's my thinking.
Anybody else got any ideas or thoughts on that?
I mean, my feeling is it's the duration of contact of the drug on the ocular surface that's key to clearing the crystals. And I think anything that is, administrable through a spray is probably not going to last long enough on the ocular surface, just given the physical properties of the actual drug preparation itself, unless it forms a gel on contact. So that's the only comment I can make on that method.
Well, time is moving on. We're going to move to Patrick. But before we do that, one of the things that has always occurred to me now, when I was in Great Ormond Street and I left in 2011, I had many, many more patients with cystinosis than I have here in Pittsburgh, but I still have about 6. And I've been looking at their tear film, and they all have a really reduced tear meniscus. And on the 2 that allow me to do tear osmolarity, it's increased. And it makes sense that the crystals get deposited in the lacrimal gland because they get deposited throughout the eye. And I do wonder if we're missing a trick here with the stinging or the discomfort. I wonder if we're not picking up the fact that these kids actually have a dry eye as well as their cystinosis crystals. And I just wondered if anybody had made that same observation about reduced tear meniscus.
They have meibomian gland dysfunction. So if you do infrared imaging of the meibomian glands, they've got destruction of meibomian glands. So they do have they have an ocular surface dysfunction in general. So it would make sense that they've got tear film problems, and we prescribe lubricants for these patients.
So I have an idea that I'll talk about in the next discussion session. For the sake of time, I'd like to invite Patrick Hamal, who is going to talk about glaucoma secondary to cystinosis and corneal imaging for cystinosis. Thank you, Patrick.
Thank you, Ken. Two things. So first of all, I'm going to talk about quantifying the corneal disease. Just as a disclosure, I've been an advisor some years ago and a presenter for Ricordati, which I'm not anymore. As we talked about, cystine crystals have been first described in the conjunctiva and the cornea. But as we know, and the more we know about cystinosis and the more instruments we have to investigate the eye, the more we know that basically those crystals are almost everywhere in the eye. These are pictures like Stephanie showed you before about crystals that are seen in the retina, even though sometimes you don't even see anything on the indirect ophthalmoscopy. Like 20 years ago, we wouldn't know that the retina might be full of crystals, but we know now thanks to the OCT. So classically, we've been using this corneal cystine crystal score that's mostly for research purposes, but it's also for clinical purposes. So basically, we put the child, or for myself or any adults, on the slit lamp and look for how much crystal there is. It's very subjective, and basically you're assessing the cornea as a 2-dimensional structure, but you know that those crystals are all over the depth of the cornea. And of course, the other problem is the slit lamp being using a light. It's a bit of a problem in those very sometimes photophobic kids. So there are other methods that have been described and used. The pentacam has been used. I saw at least one paper. I haven't done it. I do have a pentacam. The problem is you need a very collaborating kid who's not too photophobic to use the pentacam. So I don't think it's going to be used that often. We'll talk about confocal microscopy, which is great. And of course, the one probably that we're using the most, which is the intersegment OCT. Now, a confocal microscopy is very precise. It's probably one of those, the most precise of those instruments. And you really see those needle shape or spindle shape crystal deposits in between those collagen fibers. And you see them either in the stroma, in the Bowman's layer, in the epithelium, or in the Descemet's membrane. So it's great. You can also see inflammatory cells. You can see nerve alterations. You can measure crystal density at different layers or levels of the cornea, and you really see the depth of crystal deposits in the cornea. And these are some pictures from recent literature, and basically they're very, very nice. I mean, you see those spindle-shaped crystals in the epithelium. That's for letter A, and for letter D and E, you see them within the stroma. The problem with in vivo confocal microscopy, so first of all, you need to get the machine, which in my pediatric setting wouldn't be that useful in general. It is very operator dependent. It's quite time consuming, and basically the machine has light and it needs to be in contact with the cornea. So clinically, it's more or less feasible to use it. So of course, then we resort to the anterior segment OCT, either the Visente or more often the Cirrus or the Spectralis with the anterior segment lens. Instead, of course, of seeing those spindle-shaped crystals, you'll see punctate deposits in the stromal layers. So you don't see the deposits within the other layers as you would with the confocal microscopy, though. And as you know, and this is mostly in children, the crystal normally starts at the periphery and will slowly move, continue basically to deposit towards the center of the cornea, and they start entirely in the cornea and slowly continue depositing towards the posterior stroma. And that's a paper from, I believe, Dominique's team, in which they were measuring, kind of quantifying or giving a score to the crystal deposits depending on the depth, starting from the epithelium. So with ASOCT, you get much more objective measurements as compared to pictures. It's easy to perform, relatively speaking, for the operator and for the patient. And the good thing is you're using infrared spectrum of light, so you're not dealing with photosensitivity in these kids using the ASOCT. And this is quite interesting. So these are this is a child, for instance, that I've been following, and I'm still following, and you see that with time, 4 years apart, you see that indeed the crystals are slowly moving towards the posterior part of the stroma. And here, this sister who has cystinosis also has an older brother who's 7 years older, or 7 or even 8 years older. And you notice how different it is, how the sister, all the crystals are mostly in the anterior part of the stroma. And as for her older brother, it's almost everywhere in the stroma. Now, that's pretty interesting, but it was a very nice paper from Germany in 2021, and they tried to do the measurement differently. And one of the reasons is, it seems that with time, and this is something I'm not used to because I'm seeing only children, but it seems that this rule of seeing the crystals slowly moving from, anterior and slowly getting worse posteriorly is not always the case. And they are showing patients, for instance, in which all the crystals are posterior and there's nothing in the anterior part of the stroma. And what they did is very interesting. Is they basically taking a kind of a picture, a slice of the cornea, and they're bringing this into a software available from the NIH, which is called MHG. And they're basically giving a score based on how many pixels are in shades of gray above a certain threshold, and that's how they would score the whole cornea. So basically, in vivo confocal microscopy and ASOCT are probably much more reliable than pictures to quantify crystals in the cornea, especially on the clinical basis. They're more accurate. And they will help, they do help for assessment of progression, and they might be good biomarkers in the future. So I move at my second and last presentation here, which is a glaucoma in ocular cystinosis. Now, those numbers might change with time, with improvement in survival, which is absolutely great thanks to new treatments. It says that 6% of adults are or will be affected by glaucoma. Of course, this happens mostly in the infantile disease, and they tend to happen by the end of adolescence or in their third, fourth, or so on decades. The first case that I found was described in 1974 and was more like a POAG kind of glaucoma in a non-nephropathic cystinosis. Most cases described in literature are basically angle closure / pupillary block glaucoma. This is the one of the papers I could find in 1986 in which they were describing a 19-year-old woman with infantile cystinosis. And she basically developed an iris bombé due to pupillary block from what they think was thickening and stiffening of the iris. And the reason they were able to say it was thickening is that they did an iridectomy and they sent the iris to pathology. And there's a handful numbers of publications on glaucoma, and most often you'll find those cases within other papers describing series of kids or adults with cystinosis. That said, a few of those papers seems to be representing the same group of patients, so you have to be careful about the number of patients that are being reported in literature. Why do we get glaucoma and cystinosis? Different possible reasons. There seems to be posterior synechiae in some patients. There might be increased thickness of the iris stroma, as I explained in this one case. For some others, it's unclear why they were able to say that the iris stroma was thickened, because it was said before the UBM even existed. Some have been describing fixed myotic pupils, but that might be because of hidden posterior synechiae. There might be increased corneal thickness, and which would be responsible for narrowing of the angles, and vascular membranes in pupillary space have been described also. Now, a really nice paper from our colleague Ken here, which from the 2020, from 2000, sorry, was ultrasound UBM ultrasound biomicroscopy of the eye in cystinosis, in which they look at 6 patients a bit older, meaning they were aged from 6 to 25 years. And those patients didn't have any glaucoma, they had no posterior synechiae, and they did a UBM on them. Well, the first thing they did was quite interesting. They did a gonioscopy on all of them, and all of them were shown to have trabecular meshwork crystals, which might explain maybe the first case I was talking about in 1974 of this kind of POAG glaucoma in a patient. So at the UBM, they were looking at the sclera, the cornea, the iris, the angle, series sulcus, and they found a configuration similar to plateau iris with a narrower iridoid corneal angle, a shallower anterior chamber, and a closed or very narrow ciliary sulcus. They didn't find any thickened iris or cornea. And these are pictures from the paper. And on the right side, you do see the absence of space as per the series sulcus, which you see in these control patients on the left column. Why is it that there's this abnormal ciliary body configuration? It's not clear. It might be because there's ciliary body thickening, although it wasn't shown in this paper, or maybe because of those described iris ciliary adhesions, but it's really not clear. So these keep us updated risk factors for glaucoma, which are crystalline cystine crystals in the trabecular meshwork and plateau iris-like syndrome. So that said, thanks to new medication, thanks to increased life expectancy, now we're gonna have to monitor for long-term effects as glaucoma, posterior synechiae, and progressive angle closure. Thank you.
Great, thanks, Patrick. It's wonderful, the explanation and the lighting of the disease with the glaucoma, and we learned a lot, I think. And so next speaker will be Professor Susmito Biswas, so a great friend, and it will be a pleasure to listen to you about gazing into the crystal ball. Thank you, Susmito. It's all yours.
Thank you so much. I will share my presentation here. Okay, so yeah, thank you, Dominique and Ken, for inviting me to talk into this. I do have a declaration. I have been a paid consultant for Recordati and received funding. We briefly talked about, we talked extensively about managing corneal crystals, so I'll briefly go over what I do. So Cystidrops, as I said, is available in the UK. We do have mercaptamine in an aqueous formulation also available as an alternative. It's prescribed, the Cystidrops prescribed 4 times a day, mercaptamine hourly if we can, but patients very rarely achieve that. Parents take control in very young children, but teenagers like to control this. And so compliance can become a bit of an issue when they're a bit older, as we've heard. In about 50% of our cases, probably more than 50%, nephrologists actually prescribe the eye drops, interestingly enough. But I think whoever prescribes, it's important to explain the potential side effects of these eye drops carefully to parents and to children. And how do we monitor? Well, we've heard about the slit lamp examination, the GAL score, the subjectivity associated with that. Anterior segment OCT is very, very helpful, as we've already heard from Patrick. We do densitometry with the pentacam. So here's an example. This is a moderately advanced case in an older teenager with a GAL score of between 2.75 and 3. And over time, even though it's difficult to estimate this from the GAL score, we can see the densitometry is progressing. This is a person who's got poor compliance with treatment. So densitometry can be useful if you can do it. The CASIA 2 is actually an OCT machine that has densitometry function, and that actually may be a little bit more accurate than the pentacam densitometry readings. In terms of compliance, there are issues. As I mentioned before, it's important to mention the potential side effects. We give patients an information booklet. You can see that the dropper bottle design is a challenge for patients, particularly when they have this distal myopathy in their hands in the adult age group, and they find it very difficult to construct the bottles. But it's important to bear in mind that these bottles are undergoing a redesign, hopefully in the future. I've mentioned that we are quite liberal in prescribing topical lubricants to our patients. As we've heard, we know that these patients do get an inflammatory chronic inflammation. And so actually we've started thinking about using, and we are now using, cyclosporin in some of these patients long term. For those using aqueous preparations, punctal plugs make sense. I haven't personally used it, but for the aqueous drops, it's about topical contact time, and using punctal plugs can improve that aspect of it. So I'm talking about future treatments and new drugs, new delivery systems, and of course, gene therapy. Now we know that cystinosin, which is the protein at fault in cystinosis, is primarily involved in shifting cysteine out of the lysosome, but it has more functions which are becoming much more apparent in the recent years. It has roles in autophagy. So autophagy is where you're basically got recycling of organelles, excess organelles and defective organelles within the cell in order to replenish that cell function. And in cystinosis, this chaperone-mediated autophagy is felt to be affected in this particular condition. We've heard that inflammation is a process that is occurring chronically in cystinosis, and again, cystinosin has a function in that. And there is a known function in abnormal apoptosis, and it is also important in controlling responses to oxidative stress. So these all lend themselves to potential targeting for new drug treatments. So in terms of autophagy, there's a host of active compounds that can alter the autophagy flux in patients with cystinosis. For example, everolimus, which can switch off autophagy from occurring, can also have a role in controlling apoptosis, as well as responses to ATP, low levels, and oxidative stress. I want to give a little bit of a shout out to N-acetylcysteine. So N-acetylcysteine is available in drop form, but it's also known to be an important controller of apoptosis as well. And then we will talk about gene therapy in a short while. Now, we mentioned before that contact time for the drug on the ocular surface is critical. And giving hourly drops or even drops 4 times a day can be a challenge. So people have looked at other alternative means of applying the drug to the ocular surface over an extended period of time. And some work has been done in the past about loading contact lenses with cysteamine. That controlled release of cysteamine can be enhanced by adding vitamin E to the contact lens, and the AccuView TrueEye type silicone hydrogel contact lens is one that is not affected by use of cysteamine and vitamin E impregnation, and can still act as a good optical medium. So Ken has been involved in developing this thermoresponsive eye gel, which contains cysteamine as microspheres. This can be delivered into the eye and acts as a depot for slow release over a period of around 12 hours or so. And this provides some promise of a delayed release with just a once-a-day application. We've mentioned nano wafers. So nano wafers are just dehydrated HPMC type lubricants formed into a thin wafer. And within this, microwells can be placed in which cysteamine can be instilled, and this slowly dissolves over a period of time. This is in a mouse eye, and can result in delayed and sustained release of cysteamine on the ocular surface. And then this is a very interesting development. This is a theranostic contact lens. So this means that it can be used both for therapeutic and diagnostic purposes. So this is gold nanoparticles, which are impregnated onto a standard contact lens. It's stable, and when it's impregnated, it actually changes the contact lens color to a sort of red appearance. Now, this gold nanoparticle actually binds cysteine, so it's an agnostic type treatment. When it binds cysteine, it actually changes color gradually from red to blue. So you can actually track this eye color change, and it will be proportional to the amount of cysteine that's bound onto it. So again, this provides a therapeutic as well as a diagnostic promise in the future. So very interesting development, that. Gene therapy has been looked at intensively for this kind of disease. So this is an example of an intrastromal injection of an adeno-associated virus with the corrected gene in a mouse model of cystinosis. And as you can see from this slide, there is clearance of the cystine crystals from the cornea over a period of 8 weeks. So again, a very interesting development for gene therapy applied locally within the eye. There are certain groups of patients with nonsense variants in the CTNS gene. Now, these nonsense variants result in a transcript that is unstable as a messenger RNA and undergoes nonsense-mediated decay. But using aminoglycosides, you can actually manage to read through the stop codon and actually produce the full cystinosin protein. This again may provide for some certain groups of patients with this type of variant a potential treatment. So that's showing promise. And we've heard about stem cell transplants from Julian with a patient in Calgary. This has been demonstrated in animal models using stem cell transplants. In humans, the experience is still limited. There was one case report of an allogenic stem cell transplant, which did result in clearance of cystine crystals in the organs and in the eyes. But unfortunately, this allogenic stem cell transplant is prone to graft versus host disease. And unfortunately, this patient didn't survive from severe complications from graft versus host disease. But that has led to further studies looking at potentially using the patient's own stem cells and then using viral vectors to do gene therapy to those stem cells, changing them to stem cells that can express the normal CTNS gene, and then putting this back into the patient where the stem cells can then be distributed throughout the tissues and organs of the body to express normal cystinosin and restore function. So this promises a complete cure for the patients. trials of this, I believe, are currently underway and hopefully will show great promise for a cure in the future. So what I can say from this presentation is that there's a great deal of promise in the future for improving treatments, both for the eye and systemically as well. Thank you very much.
Thank you so
Thank you.
much.
No.
That was terrific. Thank you. Go ahead. I think we have some time for questions, right?
Exactly. We have some time for questions, and thank you for those two very good talks. And just looking that we have maybe more possibility of treatment. So this is great. And at least we have some, we can follow some new thing. So, do you have any question on the floor?
Yeah, we do have a question that I'm going to put to the panel. But before we do that, actually, my phone has been going a bit crazy with texts on Facebook and also on WhatsApp. So we have people want you to know that we have listeners from Belgium, Wales, Denmark, Sweden. I think we've done that already. Norway, Kenya, Zimbabwe, Bolivia, Slovenia, Greece, Cyprus, Romania, and Slovakia. So truly global. So the question that was in the audience from the audience is: would a vaulted scleral lens be useful? The vault is typically filled with saline solution. So I guess the question that they're asking is could we put I guess the aqueous drop in a vaulted scleral lens and then put that in the eye? I've never done it. There have been circumstances where it's been extreme, and I wonder if, where I had a patient who was about 24 years old at Great Ormond Street who had to have an anterior lamellar keratoplasty because she was so symptomatic. So before doing that, perhaps you could try this. Any thoughts from the ophthalmologists and Julian yourself?
I've never personally done it, but I think you could try. The other thing that I was thinking of is, I do offer lubricants. I always stress preservative-free, especially on the Cystidrops. But I mean, I was also curious about platelet-rich plasma as well, like using PRP drops potentially. So I'd be inclined to try PRP potentially before the scleral contact lens.
Go ahead, Sus.
Well, I mean, I'm just wondering if it's a means of optimizing drug delivery. In other words, having a pool of drug within that, encased within the scleral contact lens. Yeah. I suppose you got two challenges there. One is, can the person tolerate the scleral lens in the first place, and two, how much would they tolerate a pool of stingy eye drop placed on the ocular surface for that length of time? I think that those are big questions, and I don't know. I mean, it may be a way of doing it, but I think the big hurdle to overcome is how much will the patient actually tolerate that?
That's a very good question, because I'm just thinking also in children. So scleral lens, I don't know what experience you have, but for me, it's usually it's no less than 8 years old, and even 8 years old, it is very, very difficult to adapt. So it will be really a challenge to do it.
Let's go back to this idea of a punctal plug. I have used punctal plugs in two older children, and I use them with the one with the aqueous drops and one with the gel formation preparation. And I was pleased with the amount of crystal clearance. However, I did have to use preservative-free lubricants as well, just after applying the drops, especially the Cystidrops, the gel formulation, because they seem to sting more than the aqueous. Anybody else used any plugs?
Not for this.
No, it makes sense. It makes sense, but I've not used it.
This was being talked about the Cystinosis Research Foundation Day of Hope by the ophthalmologist there, who was saying that he'd been using these and found it to be helpful to retain the eye drops on the eye longer.
Yeah, the problem is that we just haven't had nobody's done the study, you know, to show what happens to the tear osmolarity, what happens to the tear lake, and kind of like developed a use the 3C score, you know, the crystalline cystinosis crystalline cornea score. So I think that probably is something that we should try and do in a multi-center manner. Let's just stop for a second, because we time is sort of running away from us. Can we agree as ophthalmologists that we need to have, because everybody on this panel is experienced in seeing cystinosis kids, but there are parts of the world and parts of the United States and parts of Canada where an ophthalmologist, a pediatric ophthalmologist or a comprehensive ophthalmologist will see a child with cystinosis for the first time, never seen one before, only read about it in the textbooks. What can we tell them that they should do as a baseline exam? I mean, I'll put some things out there and you can say to me, no, that's ridiculous, or yes. Well, we need a visual acuity, right? In some way, shape or form. We need a slit lamp photo to see what the crystals are doing. And if possible, an anterior segment OCT. I don't think an IVCM is available in every center. I would like a wide field imaging picture with autofluorescence of the retina as a baseline. And I would like an electroretinogram. What do other people feel?
I think first, just one point. First is to do the diagnosis. Sometimes it's not so easy. First of all, and that is very important because just with the slit lamp you can do it, because the crystals are really typical, they are specific. So first of all, I should say, even if you have only the slit lamp, this is very good. And then you refer to a center, but at least for this.
But you see, it's not Europe, you know. I mean,
I understand.
You have large distances, and parents don't want to travel. So what can that ophthalmologist do?
I understand. So feel free to answer, because you have the experience. Of course, I have the experience of the center.
Right.
I guess it depends a little bit on the age that the patient's presenting. So if this is occurring as a late presentation, then, you know, symptomatically, the patient may have issues, for example, night blindness, visual field problems, in which case I think an ERG would be important to do. If they're old enough to do a visual field, then do that. I think if they're very young, it's probably unlikely, in my experience anyway, and you know, I'll hear from others, but I've never encountered, even in patients who have been diagnosed a little bit late and who have some RPE changes, I've not encountered ERG problems. So I think an ERG type issue tends to be quite late in the day. But I think an OCT scan of the retina is helpful. I think I agree with you completely on the wide field imaging of the retina. I think it's important to look at the disc, because these patients do get raised intracranial pressure. It's a very important thing to have in the back of your mind, because they get Chiari malformations, but they also get raised intracranial pressure for other unknown reasons. And that's something to monitor very carefully long term for these patients. And it can present at any age, even in young childhood. So that's an important thing for a new ophthalmologist to be aware of.
Do you think an anterior segment OCT is important?
If you can do it, if you got it, yes, excellent. It's a great way of semi-objectively assessing the depth of crystal deposition.
And before I talk to the other panelists, this is a great point that you make. I mean, let's say you have a 17-year-old who's been under your care, under the nephrologist's care, and they pitch up with headaches, right? What are the things Patrick, what are the things that you worry about as an ophthalmologist? So the nephrologist says, go and see your ophthalmologist, you know, make sure that things are okay? What are the things you're going to look for?
Well, of course, one of the reasons, of course, is they get benign intracranial hypertension, and you really have to suspect that something might be wrong in that sense. And those are kids I would scan for sure. There's one thing we didn't talk about also, which might be a problem. Some of these kids are under growth hormone, and you could get problems with the optic nerves, or you could even get like benign intracranial hypertension. So I would for sure question if there's any of these drugs involved.
But so yeah, you're absolutely right, and I agree with both you and Sust about that. But the other thing this is a real case that happened to me at Great Ormond Street, and actually the patient was getting subacute angle closure glaucoma. And the headaches, when you spoke to them, were always in the evening. So I think if a child with cystinosis presents with headaches, it's of course important to make sure that there isn't any raised intracranial pressure, but it's worth bearing in mind that they could have this subacute angle closure glaucoma that you have to deal with, rather sharpishly. So we've agreed visual acuity, wide field imaging. I always get autofluorescence because sometimes I've only got one patient who has this, but they have some changes that suggest to me that it's not just the RPE, but also something happening in the photoreceptors with some autofluorescence changes. Anterior segment OCT, if you can do it, a slit lamp examination for sure, and a slit lamp photo, and an OCT of the retina. I mean, that would be bells and whistles, everything covered, right?
Right.
If you don't have everything, Stephanie, what would be your 3 basics or the 4 basics that you'd say you have to have?
The 4 basics, I think, are vision, obviously, always. That's like the vitals of the eye. So your slit, and then your slit lamp, and the OCT. Those would be, I'll even limit it. I'll say OCT, and I would do retinal and corneal. Perfect.
So Julian, we have another webinar in this series that talks about the multi-system approach and the multidisciplinary approach to cystinosis. But could you tell me a little bit about have we measured the quality of life in patients of cystinosis? Are those studies out there, and what do they tell us?
There has been some look at this. I've looked at some studies which looked at the change from dialysis to transplant, and there's a big change there. One of the things that I came across was that quality of life is particularly dependent on family support, and one study looked at school support. People at school were particularly important, independent of demographic and family situations. So I think that when you're talking to these families, making sure that they have a good school. I'm not sure that homeschooling is particularly good, because peer support can be useful. One of the problems about school is that children can be stigmatized because of the halitosis, but parents will often say, what I did was we went in, we talked to the children in the classroom, in the school, about the disease, about the issues, and actually peers at school can become very supportive and start reminding the children to take the medications, etc., and so forth. So I was very interested in that particular study where school was particularly important.
Talking about school, can I ask the ophthalmologists, what I have noticed is that as they get older, normally around early teens, the earliest one's been about actually 9 years old, but normally early teens, they can start to get an accommodative dysfunction. And I presume that's because the crystals are being deposited in the ciliary body and the ciliary muscle. And when I've done dynamic retinoscopy on these kids and teenagers, I found that they're under accommodating at 1/3 of a meter, and many of them I've ended up giving bifocals. Has anybody found that, done that, checked for that?
I haven't, but I will start.
I mean, I was surprised. The reason it happened was that a mother came in and the child was about, he was 12 or 13, and said that, the optometrist says that his vision he doesn't need glasses, but he can't read. And of course, he had 20/20 vision, and then for near he was reading, N5 or 20/20, and they can do it momentarily with the extra effort. And then when I did his dynamic retinoscopy and made him look in the distance, then for near, he was clearly under accommodating. So that was my sort of first case. And then I started looking at all of them. So I wonder, Patrick, Dominique, Shas, any experience with this?
I did not have any experience, and probably because I see them quite early, and I don't have a lot of adolescents. I see them by by the principal. So like 1 year and a half, or 2 years, or 3 years, and probably they are not enough older to get this kind of complication. So, but I can understand that, and I will try to see them. Older, and to see if there is any dysfunction of this. Yeah, this is a good point.
I've not encountered this, although I've not checked it, so it's probably worth checking. What I suppose is a little bit interesting about that observation, Ken, is the fact that the ciliary body has a good blood supply, and so if they're on oral histamine, then you would have, from an early age, you would have thought that that would provide some protection against crystal deposits, but it's clearly not working. Or is there something else going on? And it goes back to, the discussion around, what's causing some of the other effects that is not amenable to treatment with cysteamine. Why am I getting myopathies? And this goes to the other function of, the molecule, and whether we're covering all bases in these patients.
Yeah, I agree with you. I mean, time is short, and we're coming to the end of the webinar. But we haven't talked about the fact that the survivors who get into the 20s, 30s, 40s, 50s, and they do that now because the medical care is so good. I remember seeing a 26, 27-year-old with eye movement disorder, like a gradual ophthalmoplegia. And so maybe the accommodation is a central thing. I don't know. That's a great point. But I think it's worth, for anybody out there, just worth adding that because it's not a difficult thing to check. So for the sake of time, I'm going to hand it over to Dominique. Go ahead, Dominique.
Yeah. Well, so I just want to thank everybody for all these talks. And it's really nice. And probably we need one more webinar on the topic because it's not enough. And so thank you very much. But I will ask if you, from the panel, you could just make just a quick final comment or a take-home message. Each of you should be very nice. Could you provide this? Who is going first?
Let's start with Stephanie. Let's do Stephanie,
Okay.
Patrick, Sus, and then we'll let Julian have the last say.
So I think two things. One, as Julian said, families are very aware and very well educated. And two, the importance of a team approach. I can never underestimate or underemphasize how important it is to work with a team with these complex kids.
Patrick?
As for me, I would say, as I alluded in my talk, as the survival is getting much and much better for cystinosis, we have to be more and more aware of those problems that are coming later on, such as glaucoma and all those corneal problems.
Yeah, thanks. I think that it's probably a great time now to be into cystinosis. There's been a lot of increased understanding of the mechanisms of disease, and there's real promise in the future of new treatments. So I think it's a good time to be involved in cystinosis.
Thanks. Julia?
Well, thank you very much indeed. I've learned a lot from taking part in this, and the multi-system, multi-specialist care of these patients over now decades and decades is going to be more and more important. Eyes are so important to the families. It may be something that they don't want to think too much about in the early years, but as these people live into their 40s and 50s, eye care is going to be paramount. And knowing how some people look after their eyes better rather than worse just gives you a little bit of impetus to try and emphasize to those people, especially teenagers, to do those drops and get to the ophthalmologist.
That's phenomenal. I want to say that I've been on several webinars about cystinosis and listened to several. I don't think I've ever quite been on a panel that is so invested and has done so much work as individuals, both publications and with parent support organizations. So it's been a real privilege to listen to all of you. I'm going to do some sort of housekeeping as it is now, and then at the very end, I'll ask Dominique to have the final say. So if we missed any questions, I don't think we did, please email admin@wspos.org and we will get back to you with an email answer. There are upcoming WSPOS webinars. Webinar number 6 is the multidisciplinary care in cystinosis. That's the 31st of May, and it's part 2 of a 2-part IME series supported by Recordati. We're very grateful for their educational grant. We have one that's very interesting in the 4th of October. It's procedural comfort in pediatric ophthalmology and the psychological effect of, I guess, what we do to all our kids when we put drops in their eyes and other procedures. So that's something that's going to be very, very interesting. We're planning another independent medical education program focused on amblyopia with 2 webinars and a consensus statement. And in fact, Sus Biswas has just finished the consensus statement on cystinosis, so you will be seeing that pretty shortly. I've gone too far. Here we go. Let's try again. And the other thing, where are we? There we go. And in addition, we got a second WSPOS and Young Ophthalmology Society of India collaborative webinar happening later in the year. So for those of you who don't know, WSPOS does a pediatric subspecialty day before ESCRS. It's the 12th of September in Copenhagen, and there's an abstract deadline on the 4th of May. Registration opens very shortly. Hope you'll be there. Should be very exciting with an innovation evening as well, so that you'll know about all the latest startups that might have something of relevance to us. This is the preliminary program, which is pretty global, as you can see. Do become a member. It's free. It's free. These are all the membership benefits, and it's worth doing. You get lots of video exposure, and I hope you'll do that. Membership is free. It is never, ever not going to be free. Join us at WSPOS. David Granite runs an international listserv. If you want to join, requires your full name, where you did your training, and it's a great community. He's been running it now for well over 30 years. Okay, International Congenital Corneal Opacification Network. This is the QR code. If you are interested in being part of this network, take a picture of the QR code. Don't worry if you don't get it now. This webinar will be running on YouTube. Register so that we know. We already have about 300 people, and we're going to be doing a couple of virtual meetings. I want to thank our audience. I want to thank our panelists. Really, I can't tell you how amazing this webinar has been. Do everybody who's been listening to this live, do tell your residents, your fellows, your nephrology colleagues, if they're not listening, that this is, I hope, Julian, you'll tell your nephrology networks that this was worth listening to at least once, even if it's in the background while they're doing something else. Thank you to Recordati for the Independent Medical Education Grant. Thank you to NTOD for running this. The only other person she never does this, Ocular never puts her own name on here. Ocular has been instrumental in herding all of us, and I want to thank her very, very much indeed. So I'm going to stop sharing there. And Dominique, last word.
Just one point. I would like to thank you, Ken, for organizing, and it's great to have this great panel too, and this innovative treatment at the time and on the coming next time. So thank you for all.
Thank you very much. And you guys all kept on time. So I think that's the first time.
Wow.
Thank you much. I hope wherever you are in the world that there is peace this weekend and that goodwill will prevail in the end. God bless everybody. Bye-bye.
Bye-bye.
Bye now.